We're going to talk about arthritis and regenerative therapy and different options, which would mostly be regenerative of stem cells or PRP, PRF. And I've spoken before about PRP and PRF, what the differences are. They're almost the same. We usually either activate the PRP to make a PRF, or you get straight PRF, platelet-rich plasma, platelet-rich fibrin. And then stem cells typically are either adipose-derived, meaning it comes from your fat cells, or derived from the bone marrow. We have clinically only used adipose-derived stem cells for the past 10, 11 years. Bone marrow stem cells have been around for a long time as well. Some people feel bone marrow stem cells may be inferior because there's less mesenchymal stem cells per, say, centimeter of bone marrow than there's a fat. However, there's not good clinical evidence to show there is much of a clinical difference. Large meta-analysis, which is a grouping of multiple studies, showed superiority of fat-derived stem cells, but I can also find papers that showed that they work about the same. So let's talk about, somebody has arthritis. It's a big common problem in America. If you look at people over 60, it's about 35% of women and 15% of men have clinically significant arthritis, most commonly knees. And this does impair activity, which impairs health span and lifespan, longevity, and mostly because of more limited activity. As we get older, we want to be more active versus less active to stave off disease. Pretty much every disease is more associated with inactivity. So being mobile is crucial, and you're only as good as your worst joint. So if we have a knee arthritis, we want to address that. And surgery is certainly one option. There's some concerns regarding surgery with the big downtime and how long the surgical implants last. So a lot of people are looking for regenerative therapy to try to use their own cells to heal their tissues. And we've been doing this for over 10 years at Allure. So I'm going to go kind of over the different options and what might be the pros and cons of each. So step one would be, and again, I'm not talking about the conventional medical treatment, which is not regenerative. That is using steroids, which actually hasten or accelerate the time when you'll need an arthritis surgery, or hyaluronic acid, which is a lubricant. It's not really an acid, it's more of a sugar alcohol, but it's more of a sugar, but it's a lubricant for the joint that does reduce symptoms, but does not put off surgery substantially. So we're looking at regenerative therapy, which is using your body's cells to heal the tissue, potentially increase the cartilage and decrease the inflammation and pain. So PRP and PRF, I've spoken about this before. This is really like the mainstay of regenerative medicine. It's using your body's own platelets, which are designed to heal. And they have three key growth factors: transformative growth factor, beta-3, VEGF or vascular endothelial growth factor, and PDGF, platelet-derived growth factor. Each of these has something to do with making the tissues healthier. The VEGF, that helps bring circulation in, to give the nutrients needed and the oxygen needed for tissues to rebuild. The platelet-derived growth factor recruits surrounding cells to heal and grow back tissues, and the transformative growth factors has those multiply and grow. Clinical studies have shown that typically a PRP, PRF injection, I use those terms interchangeably, they're basically the same thing in the way we use it in 2024-25, gives you relief for some number of months to a year. And it's something that could be done repeatedly, could be done every year. It's very simple. You take the blood and do an injection. It works. There's been studies mostly with more mild to moderate arthritis, but recent studies in more advanced arthritis show it works there as well. Maybe not as well, but it works there as well. About 80% success rate over 3 years. So that's really a good option for us. And what we're doing now is doing usually three platelet-rich plasma, platelet-rich fibrin injections in the first year, and then about 1 a year after that for maintenance. So that's a good option for people. You can do it more than that, but that'd be pretty typical. And then there's stem cells using fat or bone marrow, and there's also something called micro-fragmented or nano fat, which is basically a stem cell type procedure. Well, it's technically not called that. That's what it is. So the nano fat or micro-fragmented fat, that's where fat's extracted. And a kit, there's a few kits out there. One's lipogems that we've used. There's also different devices using Venturi effect where you can break the fat out. So we suction fat out of somebody's body, out of your stomach or thighs or something. They only need about, say, 10 teaspoons. And it's basically put in a device that pulverizes the fat, breaking the actual adipocytes, which frees up the stem cells, frees up the mesenchymal stem cells, which are abundant in your fat tissue. You have about 500 times more stem cells in your fat than in your bone marrow of mesenchymal. That's the type we want, which is for the tissues we're looking to heal in the knee per teaspoon. Okay, about 500 times more. So we take the fat, basically grind it up, and inject that slurry into the joint. And that gives relief, typically on order of about a year. And actually, it compares well to PRP. So if somebody does PRP or nanofat, microfat, lipogems, it lasts about the same, about a year. People get a similar improvement. There's a potential for the PRP to be done a second time easier than the nanofat, because the nanofat requires liposuction, but they're somewhat comparable. So we can say those are comparable. But then taking that a step further, if we're getting the fat out, we can take another 10 teaspoons and send it to a lab to extract your stem cells out and then bank them. So there's banks that bank, say, placental stem cells from your baby. You can also bank the stem cells out of your fat. So we send the fat to a lab. In our case, we use a lab in Florida. They process the stem cells out and then they culture them and grow them, so expand them. And then they bank them for the rest of your life. You can have them banked for the rest of your life. This is an annual fee, but it's very minimal. And then when you want stem cells, we send them a fee and they send us 10 million stem cells. That's not really for 2 joints, and they can go into your joints. So that's the type of thing we're doing now. Now, we used to have our own lab to make our own stem cells. There's been a lot of government regulation making that more difficult. So now we just use an outside lab. And then there's bone marrow derived stem cells, which we don't use in our clinic. Nothing wrong with them, but we don't use those. The bone marrow hurts more to obtain it. And I'm not familiar with that, but we have more of a plastic surgery business. So we know how to get liposuction, and hurts less, easy for us to do. And there's more stem cells, and it works at least as good, if not better than bone marrow. So again, I say at least as good, if not better. Probably works better in some studies. Other studies, it shows the same. So bone marrow is fine. Okay, so what is how should you approach this? Well, first off, we can grade the arthritis from 1 to 4. And the closer you are to a 4, which is bone on bone, we might more be thinking about stem cells, perhaps doing PRP to get you along until you're doing your stem cells, or see how you respond to that. But you might be more the stem cell patient to put off knee replacement longer further off, or maybe potentially putting it off forever. In a large study of people that had more advanced arthritis, level 4, which is the highest arthritis, they found roughly just below 80% of people were able to get 3 years without needing a surgery. In other words, their pain was reduced at least 50% or more, where they didn't functionally need to do a surgery. So that's pretty good, 4 out of 5 people. With that being said, stem cells have been shown to relieve arthritis symptoms as well as PRP. Not necessarily better relief, because they both relieve symptoms quite well. Typically, we'll see a 50 to 80% improvement of symptoms with the first PRP injection. You can do more, get better results. We can see that with stem cells as well. But the stem cells seem to have more durability. They last longer. Studies have shown people out 5 to 7 years having still better than their baseline. They might have decided to do it again to get more better, but they're better than their baseline 5 to 7 years later. What about fixing the knee? So we might use radiographs or MRI to see, is the knee cartilage growing back? So the jury's out on PRP and cartilage regrowth. I have found papers that showed some improvement of radiologic imaging where the cartilage did appear to improve over time. And there's other papers saying, not so much changes. It just stabilizes symptoms and makes it not get worse, but doesn't actually reverse it, where there's been numerous papers showing with stem cells that there's more cartilage regrowth. The space gets bigger, so there's a bigger cushion between the bones. The MRI looks better, the x-rays look better, so you're functionally improving in addition to be symptomatically improving. So where are we at today? So we're going into 2025. We've been doing this for over 10 years, a lot of experience with it. I was part of a big stem cell group, so we were part of a research paper. So a lot of background. And my personal thoughts are the PRP is a very low expense, and if it's going to work for you, that's fantastic. If you get significant relief, you can continue to do periodic injections. Very simple. You're just like doing a blood test to get your blood. Then we inject it in your knee. It's not painless, but it's almost painless. And if that's working, that's great. And high probability you put off doing surgery if you're a candidate for surgery for years, if not hopefully forever. But you're not going to turn the clock back on the appearance of the knee very much. So long term, we might think that the PRP platelets may fail eventually. In fact, in the longest study I've read on PRP, it's a 3-year study. Year 1, it was like a 90+% success rate. Year 2, about 90%. Year 3, about 80%. So people were sort of falling off and needing to, do other interventions. So still good long-term success with advanced arthritis, but that's maybe the limitation is as more advanced, you might need to do something else. We're talking about micro-fragmented fat. Okay, so if we're going to do stem cell therapy, might as well do the micro-fragmented fat at that time. It's very simple. It's the same procedure. We take your fat out, grind it up. We can add PRP to it if we want to. We can do it alone and put that into your knee while we send your stem cells, your fat basically, to a stem cell lab that'll extract your stem cells out, expand them or grow them, and then bank them, indefinitely for you if you choose to pay for that. This is a good option for the person that wants to turn their joints around, improve the radius, and actually make their joints appear younger than they are today. So PRP will make them stabilize. Stem cells potentially makes them younger. Plus, you have the ability to do that for other joints. You can order more stem cells from the bank and do that. Of course, you can always do that with PRP. You've got your own bank in your blood system. The way I'm approaching this now is somebody with grade 1 through 3 arthritis. Let's start with doing PRP and see how you do. And then consider at some point making the investment into the stem cell bank because there's an expense. You got to do the procedure to get the fat out. Doesn't really hurt much or anything like that, but there's a cost to it. And then we've got to ship the fat down to a bank that extracts the stem cells and grows them. Again, there's an expense to that. And then you bank them, which is really not that expensive. That's something that is really easy to do right now. It was not easy to do 10 years ago. Again, we had to build our own lab at that time. Now there's an outside lab we can use. And if your arthritis is advanced, now you could do that and then keep those stem cells and you're going to get more durability out of the injections. So when you decide to treat the other knee or your hip, shoulder, you've got a more robust treatment. Again, not more robust in terms of reducing symptoms necessarily, but more robust in terms of durability. How long is it going to last on the order of years versus 6 months to a year, and remodeling the joint in a more favorable way. So these can be used in combination as well. We have a program where you can do the stem cell membership, the PRP membership, which allows you to do a series of treatments, very, very low cost. And then the stem cells, you can get those at a reduced rate as well, where you would ship your stem cells down to the lab, get them isolated, and then they can ship them to us and we can inject them into your knee. So that's the story of, what are your best options? I think, the combination therapy is going to be platelet-rich plasma without hyaluronic acid. I think at some point, hyaluronic acid is a good structural benefit if you're not doing stem cells. If you are doing stem cells, the hyaluronic acid is not needed. If you're not sure if you want to do stem cells, you can start with the PRP now to get yourself some relief and then get a chance to think about it and, put the economic might behind it when you're ready. Again, banking them is relatively inexpensive and retrieving them is relatively inexpensive. A lot of people are going to Panama and other countries to do this. You don't need to anymore. The government has been trying to regulate stem cells, mostly because the FDA is, I won't say in the pocket of big pharma, but they work for big pharma. They're trying to approve drugs, and they ostensibly are trying to make drugs safe for consumers. But we can see several times where they've approved drugs that really didn't work, that got the backing of the FDA as if they did work. And this does happen. And stem cells, we consider this more of a surgical procedure. And there's currently a company, Cellularity, that's trying to make a stem cell product FDA approved so they can sell it at a gajillion dollars. And I think that's led the FDA to maybe start looking at stem cells. So there's a time that they were going after doctors for enzymatically processing stem cells and went to court. Government ultimately lost. They did an appeals and something happened with that. So right now we're just using an outside lab that does it because I'm not sure we're allowed to process your stem cells in the office anymore like we did 10 years ago. It's here to stay. It's not going away. In spite of the FDA's best efforts to make it go away, it's still available. Umbilical stem cells are available too. I didn't really talk about that during this meeting much. We do have umbilical stem cells. The logic being that they're younger stem cells and they're from somebody else. They're from a healthy baby donor. Mother donated her baby's umbilical cord or placenta. That's an option as well. Bone marrow, we're not doing that here at Allure, but that's an option for you as well. But what I would say is overall, before you consider a joint replacement or living with the pain, look at doing some regenerative therapy. Living with the pain, if it's impairing your mobility, it does have a negative effect on your quality of life and your longevity. It does shorten your lifespan. We want to be active as we get older, not inactive. And this is something that's available to you now. Thank you.